Okay, so when the talk was first assigned, they did not tell me what they were going to name it. They apparently rejected my idea of the best pediatric cardiology talk ever given, and they just put it down to pearls of wisdom. So when I took this home to my family, this was the look that I got from basically all of them, including our dog. And they said, well, what are you going to do with pearls of wisdom? And one of my children said, there's no way I have enough to fill 30 minutes. And the other one said, please don't tell dad jokes for 30 minutes. So I've gotten over that, and we do actually have some content. Can you go to the next slide, please? I do not have any financial relationships to disclose, but I am open to offers. So just email me for my Venmo account. Next slide, please. So what I decided to talk about today was sports and cardiology. And I'm going to talk about kind of the most common things that we use to actually limit sports, but I want to make sure that I don't do any harm. So in the words of Dick Butkus, a famous linebacker of the Chicago Bears, I would never set out to hurt anyone deliberately unless it was, important, like a league game or something. So I want to talk about the risk factors for sports, but I want to first start off by saying that I'm a huge advocate. And in fact, I think that these risk factors should be kept in very tight guidelines. I think as we come out of or hopefully work our way out of this pandemic, that exercise is actually going to be the medicine that does most for us, especially in the pediatric population. Next slide, please. These are some of the abbreviations that will be used in the presentation. Next slide, please. Talking a little bit about sports and cardiology, there are a lot of athletes in the United States and across the world. And I think that these are just college and professional athletes, but if you look at overall athletes that participate in any form of sports, the number is not really that large. Only about 20% of Americans do enough exercise to meet the minimum criteria that's been laid out by the American Heart Association for heart health. And so we certainly want to continue to encourage everyone, especially this pediatric population, to be physically active, because as we know, if children are physically active, they're much more likely to be physically active when they get older. And exercise, I believe, is going to be the true medicine that helps us out of this state that we're in. Next, please. So the incidence of sudden cardiac death is actually not very high. And a lot of times we start to get the impression that we have a bunch of ticking time bombs running around on our various football fields, soccer pitches, and swimming pools, volleyball courts, etc. But the reality is, if you look at the overall amount of time that these young people spend in their sport, their risk is relatively low. You look at the numbers there, and you look at one in about 134,000 a year for males and one in about 750,000 a year for females. One of the favorite things that friends of mine who don't believe that running is a good idea is they always like to point out the marathon runners who drop dead. And in fairness, that is something that can occur, but the reality is even those that experience drop in a marathon are more likely to recover well, as long as they can overcome that initial event, and they certainly have a higher quality of life overall when they compare people who are fit versus those who are not. So running a marathon is not a death sentence, though it sometimes feels like that in the middle of it. Next slide, please. All right, so if you look at the basis of what we're concerned about, by far the number one problem in sports with sudden cardiac death is going to be hypertrophic cardiomyopathy. Now, I'm old enough to remember this as multiple other names, and there may be some on here who actually are as well, but it used to be called idiopathic hypertrophic subaortic stenosis. It's also known as HOCM, hypertrophic obstructive cardiomyopathy, but we tend now to limit it to hypertrophic cardiomyopathy. The belief being that it used to be okay if it was not obstructive and safe to participate, but the reality is that's not actually necessarily true, and it does need some risk stratification when we talk about these these athletes. There's coronary anomalies as well. One of the other more common things that gets left out of a lot of these lists is something called commotio cordis, and we're going to talk a little bit about that as well. Next slide, please. So we look at these again, and by far hypertrophic cardiomyopathy is the largest group of patients. Next slide, please. If you look at if we're trying to pick these patients out of the large number of patients that you see in your clinics every day, we can use these pre-participation physicals to give us some idea of patients that might be giving us some overt signs that there's a problem. So if they're having exertional chest pain or unexplained passing out, especially if there's no prodrome associated with that. If they suddenly just can't keep up with what they used to be able to do, or if there's a new heart murmur that you either hear about or you hear on your own. If their blood pressure is elevated, this can also be helpful. Family history is a huge guideline for us relative to risk factors for kids. So if there's a history of sudden unexpected death in a family member, especially 50 years or younger with heart disease in more than one relative, these are the kind of questions that we can be asking each time we talk to these young people, and then kind of use that to guide which direction we need to take them. Next slide, please. Hank Gathers was a young man whose career in basketball was cut short. Next slide. By hypertrophic obstructive cardiomyopathy. Hypertrophic cardiomyopathy is noted by the presence of asymmetric thickening of the cardiac myocardium, and it can be obstructive, but it does not necessarily have to be obstructive. And we know that these patients have a disarray of their cardiac muscles, of their heart muscle, that makes them at an increased risk ventricular arrhythmias, especially life-threatening ventricular arrhythmias. So that's why we've pushed to change it more to hypertrophic cardiomyopathy. Next slide, please. I think you can tell that if you look at the left side of the screen, on your left-hand side, there's the right ventricle. In the middle is a very large intraventricular septum, and then the left ventricle is to the right on your screen. And that can be a problem from an obstruction standpoint, even more so from a rhythm standpoint. Next slide, please. When we get EKGs of patients, one of the areas that can be very difficult to separate is if the patient has left ventricular hypertrophy by voltage criteria, and is that something that's bad? Those of us who take care of athletes recognize that if you reach a certain degree of elite athlete, they're almost all going to show some degree of left heart enlargement, left heart thickening, depending on what style of exercise that they do. If a patient shows up with an EKG that looks like this, you can see in the inferior, the 2, 3, and AVF, and the lateral precordial leads, that the T waves are flipped. And this is the kind that makes cardiologists kind of cringe and say, this patient needs to come see us and we need to start working on them. Next slide, please. Commotio cordis, actually, if you look at the Bethesda, the 36th meeting of Bethesda's sports clearance conference, commotio cordis came in second place for the #1 cause of sudden cardiac death in young athletes. And I think we kind of don't think much about commotio cordis. In fact, growing up, I remember playing baseball and being taught at third base that if you can't get your glove in front of it, just make sure that it hits you in the chest and then falls to the ground and you can throw it. What a great idea. We just thought that seemed awesome. And for the most part, it turned out okay. But this is the second most common cause of traumatic death. It causes a sudden arrhythmia, usually ventricular fibrillation, and it's caused by blunt force trauma in projectile sports. So you're talking about sports like baseball, hockey, that tend to usually have to be relatively small projectiles. So field hockey would be another one that we would need to be cautious with. Lacrosse, same idea. Next slide, please. And next slide, please. When they did studies on this, they actually did studies using pigs in St. Louis when I was there, and they could tell by shooting tennis balls during a and EKG tracing at what point in the window or what part of the EKG cycle they were at the most vulnerable and when they were at risk. If they have a stimulus from a projectile to put them into a ventricular arrhythmia. And you can see that window is fairly small. If that's the entire cardiac cycle, that window for vulnerability is relatively small. Next slide, please. What we see though is that if you just happen to have enough times where this happens, it does put you at risk. This is a hockey player. One of the things that happens with hockey and other sports that carry, they actually have chest protection, but as they reach up to try to stop something, it pulls the protector right up, leaving their heart exposed and makes them more likely to be a victim of this form of sudden cardiac death. There have been a lot of changes in baseball, for example. There are now shirts that are kind of chest protectors that help to spread out, that help to spread out the impact of the projectile so that it's not such a sudden and impactful force that hits them in the chest. Again, teaching children that you should avoid getting hit in the chest with projectiles if at all possible. If you can't catch it in your glove, well, maybe that was just a really good hit. But the reality of this is that in order for us to kind of encourage or to save these young athletes, we really should, as health representatives, be encouraging sports venues, schools, et cetera, to have AEDs available, both for hypertrophic cardiomyopathy and commotio cordis. The difference between surviving and being diagnosed with it and not may simply be the presence of an AED at the event. Next. Pistol Pete Maravich was the best free throw shooter of his time. Many of you are now wondering how old I really am, since these are the people I picked, but Pistol Pete Maravich died too soon because of a coronary artery anomaly. And one of the things that I think that you can see between this and hypertrophic cardiomyopathy is the fact that some of these athletes will actually make it to the top levels of their sport, never being diagnosed with a problem. You can see here that these different coronary artery anomalies have shared within them that they tend to be pushed between the two great vessels. And so at rest, the great vessels size is okay. But when we start to exercise, they can actually swell to help with the increased cardiac output. And that can put compression on the coronary artery. And what that leads to then is typically ischemia, but also abnormal rhythms, which again, are life-threatening. Next, please. So looking at coronary arteries, Dr. Kurtz would be proud of me that I included IVUS pictures in here. This is intravascular ultrasound, and you can actually see the difference in the size of the coronary artery here based on the brightness, whether it's closer or farther away from the dark circle there. Next, please. And next, please. So the mechanism of sudden death, as we talked about, is very frequently in these patients that we just talked about going to be an arrhythmia, and usually a ventricular arrhythmia. So if we look on the left-hand side of the slide here, what we see is that there's ventricular tachycardia, and you can see that the wide complex are fairly uniform as they go. The ventricular tachycardias are fairly easy to identify when you have an EKG, but can be difficult to identify in a young athlete who's just describing palpitations or who's just saying that they just don't feel as well when they are running. The normal EKG in the middle obviously would not be mistaken for that, but if you look at the one on the right, we see the one that scares us all to death, and that's polymorphic ventricular tachycardia or ventricular fibrillation. And this is the drop dead rhythm. This is the rhythm that we're trying to prevent. Next, please. You can see here, this is an example of that. When you start with the athlete going along, you see that there's some kind of ventricular beats running in short, non-sustained ventricular tachycardia that's then sustained ventricular tachycardia and finally devolves into ventricular fibrillation, followed, fortunately in this case, by a shock and a return to sinus rhythm. This was in a patient with hypertrophic cardiomyopathy. Next, please. I want to talk a little bit about Marfan syndrome. Now, before any of you write letters to me about how we don't know if Abe Lincoln had Marfan's, that's true. But what I wanted to point out in this situation is that many times patients are sent to us because they look like Marfan syndrome. And the point that I usually make with patients is that while it's appropriate to be screened and to look at and make sure that they're safe, if everyone who is tall with long arms and big hands had Marfan syndrome, the NBA would be a completely different game. So I just wanted to kind of point out that difference, that despite the fact that we completely agree with you that Marfanoid features need to be evaluated and need to be put into a risk stratification, that we do want to make sure that these patients aren't just limited out of our own concern without more information. Next, please. Marfan syndrome's concern is related to the dilation of the aortic root. Primarily, there are other issues that can go along with mitral valve prolapse, but in this picture, this MRI, the aortic root is obviously very dilated. It's right in the middle of the screen. Next. And one more time. In this case, you see what can happen is that line going right through the aorta is an aortic dissection, and this puts them at risk. If you suddenly dissect, you can increase the size of the dissection and decrease the size of the aortic lumen, and that can lead to sudden death. This is why these patients tend to be limited in what we allow them to do significantly. No contact sports. We certainly don't want them lifting weights, etc. Next, please. Here's a pathologic study of that. Next, please. So when we look at a patient who we think has Marfan syndrome, we don't want them grunting. We don't want them straining. I would never let Abe Lincoln split rails, though I've been told that he was the best rail splitter ever. Next. Last thing that I want to talk about is called arrhythmogenic right ventricular dysplasia, or arrhythmogenic right ventricular cardiomyopathy. The reason I say it went in Rome is that this was actually more prevalent in the Mediterranean. In fact, there's an island called Naxos off of Greece where there actually is a complete phenotype there of arrhythmogenic right ventricular dysplasia. Next, please. This is characterized by changes in the right ventricular wall, although it can also include the left ventricle where they get fatty and fibrous deposits. Next, please. And one more time. This is identified at times by EKG with something called an epsilon wave. And this is that small little ditzel that comes in right after the QRS complex. They're seen here in V3. Next, please. If you look at the MRI, you can see the difference in the myocardium there with the different color. The right ventricle is the one that's closest to the top. With that fatty infiltration and fibrous infiltration, it puts them at risk for abnormal ventricular rhythms based on the electrical impulse traveling through the myocardium and being disrupted. Next, please. So this picture, the one on the top is normal myocardium. The one on the bottom, you can see the fatty cells, the fibrous cells that are incorporated into the right ventricle or in times the left ventricle, but that disrupt that the myocardial cells from each other. Next, please. All right, so these are the restrictions. Those we can look up. I'm going to go to the next slide, please. Dr. Maksud did a great job of talking about COVID-19 and MISC return to play with myocarditis. Next, please. This algorithm is a great myocarditis return to play algorithm. I want to talk a little bit, since she did such a good job of that. Next, please. And next, please. These are all available through a PDF. I'm skipping to the end because I have a topic that I just want to share with you in my last few minutes here. Next, please. Screening wise, we definitely recommend that screening take maybe a little bit more intense step. Resting EKGs are not required necessarily, but I find that they can be very helpful, and they can also help us be more likely to allow an athlete to return to play sooner rather than later if we stick strictly to what their symptoms are. Next, please. And one more. So once we have these questions, the last thing I want to talk about, there's more on my slides, but I want to talk about something that came up with Dr. Maksud. And this is as these patients start to return to play. So the guidelines laid out by the KHSAA are fairly strict. And one of the most common things that I've had happen is that these athletes will come to me. I'll even clear them to say this, their heart looks fine, they look safe. And the next thing I know, they're back to my office because they've been restricted again based on these guidelines. And I'm not saying not to use the guidelines. I think the guidelines are good and that they help and make sure that people are safe, but we're setting some of these patients up to fail. And let's talk a little bit why that is. The guidelines are based strictly on, sorry, I don't have a slide for this, so we're just gonna leave it where it is. When the guidelines are based strictly on time and heart rate, we have to look at what things cause young people's heart rates to be more elevated than you would expect them to be. So let's start off with the pandemic. So many of us went through our early childhood, school, high school, even into college, participating in athletics, and we never ever had an off season. We were never truly out of shape. And that was the standard for most of these young high school athletes. They've never been out of shape in their life until now. Many of them, because of the pandemic, have been forced to just lay low for a while. And because of that, they are out of shape. So as they return to play, especially if they've had COVID and have an increased risk for orthostatic symptoms, their heart rates are going to be elevated. And we need to prepare them for that and recognize that they're going to need to get back into shape. That's an important part of what they're going to need to do. Second of all, we know with orthostatic, especially once we've cleared their heart, we know that with orthostatic symptoms, one of the primary things that we see is elevated heart rates. And so they're kind of setting themselves up to fail, or we're setting them up to fail if we don't encourage hydration. Remember, hydration and physical fitness are the two things that improve preload into our heart. And by improving preload into our heart, we're going to also improve their cardiac response to exercise and be able to lower their heart rates and allow them to move through the tiers. So I think that we are now to the end of my time, but I just wanted to make sure that we set these patients up to succeed as they return to play. I'm absolutely convinced that the way through and out of this pandemic, whether it is physical, emotional, or just a sense of well-being, is with exercise as medicine.
Thank you so much for that great talk, Dr. McCumber. I don't see any questions in the chat. I think that was really helpful for everyone as a baseline, especially with return to play and in the setting of COVID. One thing you brought up at the beginning and then reiterated at the end is the problems with lack of activity. So in these kids who, we're a pediatrician waiting for them to see a cardiologist and we're concerned and we're restricting them, but not wanting to cause some of those problems. What are some activities that are okay even while they're restricted?
Yeah, thank you. So actually the ability to exercise should really be based on their symptoms. So it depends on what their symptoms were, but if we can have them exercise in even a low key, even a walk, where we're keeping their perceived exertion at a very low level, where we're keeping them basically feeling like they're doing just fine. It's not even hard work. If we can have them exercising 30 minutes of just walking every night, that's going to keep their level of fitness up until they come see the cardiologist, and we can potentially move them forward from that standpoint. We can also allow them to participate maybe at a little bit of an increased level, but set guidelines such as if you have chest pain, then stop until you see someone else. If you feel dizzy, then stop until you get cleared. Sometimes we can just kind of look at their history and through that allow them to participate up to a level that keeps their fitness level up until they can be seen. And again, if the question is, we really think that this patient is at risk, a phone call to a cardiologist can either get them in sooner or can help with the idea of what's the next best step for them. So I would not hesitate to reach out if you have a young athlete or even just a young person interested in being active. Even more so, if you have a young person interested in being active, please don't put limits on them until we know for sure we need to, because that really is key.
Yeah, thank you. I think that's something that I think Dr. Mata would agree with from her talk earlier. Another one, we all get these patients who, well, grandfather had a heart attack when he was 75, or someone in the family had heart disease, but I don't remember. What are the things you look for in the family history that kind of raise your suspicion and says, oh, this is someone who needs to go see a cardiologist?
Yeah, absolutely. So I look at the very first thing that I look at is where did that fall in that person? First of all, where do they fall in the family? So, great Uncle Joe died of a heart attack in 1960. Well, everybody died of a heart attack in 1960. Even if you got run over by a car, on your death certificate, it says you died of a heart attack. The next thing that I look at, though, is especially if it's somebody who's close enough that I need to know what's going on. If grandpa had a heart attack, his first heart attack at 40 years of age, and he's still with us, then the first question I'll ask is, what were his risk factors? What were grandfather's risk factors? Because we know if grandfather was a marathon runner and he had his first heart attack at 40, that's a significantly different profile of his cardiac genetics than if grandfather, ate 2 pounds of bacon every day and smoked cigarettes and cigars and was, 100 pounds overweight. Now, that doesn't mean necessarily that I would not screen the child in that case. I would screen the child for the same things that I think are important. Blood pressure, hypertension is one of the highest risk factors for cardiovascular disease, and it starts in kids. Cholesterol, I would look at their cholesterol, and I would talk to the parents about their own profile as well, because that can be helpful to know what I can anticipate to help the child with. And then I would look at their activity level. So if grandfather had a stressful desk job, that's different than if he was a very physically active person. And I look at the family, are they physically active or are they not physically active? I look at the child and say, does he have more screen time than activity level? All of those things might put him at risk. And I think, whether or not he should be allowed to play, I think comes down to, how scary the family history is. But all of those other things are the risk factors for what's going to happen in his life. And so I kind of tend to focus on those, recognizing that, by the time they get to me, I can clear his heart and move along. So from a pediatrician standpoint, I would say, a family history like that, I would probably send him to see us. If he's asymptomatic, I would not, if he's asymptomatic with no known disease in himself, then the recommendations are that he not be limited.
Awesome. Thank you so much. Looks like we're nearing the time for the next session, so we want to keep us on track. But thank you, Dr. McCumber. That was a great talk.